Yes.
Lawrence, if we could have the document back up on screen, RLIT 301379. And it's internal pages 5 to 6. So just to go back, Dr. Raine, if I may, to what was set out in paragraphs 116, where the review repeatedly stated the system does not know how many women have been treated for a particular condition, or how many have been prescribed a particular device, or how many have been prescribed a particular medicine. What systems exist now to capture that information? Is that something the MHRA is involved with, trying to now have a comprehensive idea of how many people are treated?
In terms of the specific issues covered by the Independent Review of Medicines and Medical Device Safety, we have a registry of valproate-treated women, which has been constructed using the Health Services accessible data, business authority data, so that we can actually understand how many women are being treated at the moment and change over time. So that's one data set. And I believe there are other, within the Department of Health, ways of understanding women who've been exposed to surgery with mesh. In more general terms, we will rely on being able to create data systems through the new measures in the Medicines and Medical Devices Act.
And then more broadly in relation to this review, it obviously contained substantial and outspoken criticisms in a number of respects across the whole healthcare system, so by no means limited to the MHRA. But from the MHRA's perspective, can you help us understand why it took that review to bring these matters to light and bring about a response, and why these matters hadn't been identified and addressed earlier?
I would say that the special aspects of this review were the powerful voices from women themselves who raised the issue to attention in such a clear and prominent way, and were altruistic in the sense that, having suffered themselves, they were going to do everything in their power to ensure that there was learning from this. That, for me, is the main message, and their description of their own personal care pathways or not, and where the disconnects had been, or lack of clear ownership of their own care. I'm stepping a little bit beyond the MHRA's remit, but to the extent that everything we do must be with the patient in mind, we need to go beyond perhaps issuing a license and understanding much more about outcomes for the patients who will receive a particular treatment. Obviously not a license in the case of a device, but the drift is, if something's on the market, we should be very informed. All of our measures should be informed by what happens in practice.
And would you agree that it obviously it shouldn't take the voices of women speaking out, or patients speaking out in that way, to identify flaws or inadequacies in a system? And if you do agree with that, what, if anything, is the MHRA doing to try and ensure that it doesn't have to rely upon patients suffering in order for problems in the systems to be identified?
Absolutely, and there need to be effective interrelationships. We've spoken about data sharing between data collection systems, data linkage, as it were, but also bodies themselves being prepared to align, as we do when we discuss with the Care Quality Commission or UKHSA, align on a particular challenge and work in a synergistic way. At the moment, with other arm's length bodies, we're bringing together partnerships, I will call it that, supported by a new group within the agency, our transformed structure, that exists to drive forward meaningful partnerships that have commonly agreed outcomes. In other words, they meaningfully add value. Of the 15 or so arm's length bodies in the Department of Health and Social Care, that we actually evolve those fixed groupings that, in terms of safety or in access, where we work closely with the National Institute for Health and Care Excellence, that we actually keep the handle on evidence, change over time, and constantly strive to improve the systems we operate.
We can take that down, thank you, Lawrence. Dr. Raine, last week the inquiry heard from Professor Ian Roberts, and I know you've been sent a copy of his statement. And you'll have seen from that he talked about a product called tranexamic acid, described as safe, effective, and reducing the need for blood transfusion. And he had talked in his statement and told us when he gave his evidence that this was an issue about how advantageous it could be in terms of safety for tranexamic acid to be used more widely and reduce the need for blood transfusion. And he flagged this up with a number of different bodies and organisations over the years, effectively to little avail. First of all, do you know anything in terms of Professor Roberts' contacts with the MHRA? Do you know anything about that or the MHRA's response?
I have checked since he gave his important statement, and he was in touch with our organisation in 2018 via a letter to the Health Minister. I am not able to tell the inquiry what resulted from that. What I do know is that, as expressed to the inquiry just last week, Professor Roberts is concerned that there should be full benefit of the availability of this product. He has stressed the existence of the NICE guidelines and less than 100% uptake, which is something we in the MHRA obviously recognise in terms of changing health professional behaviour. I would be more than happy to further engage if there's anything that the regulator can do. I would say that the current summary of product characteristics for tranexamic acid, at least the intravenous formulation, does permit use in obstetric disorders, of which one would assume postpartum hemorrhage is one, and major surgical interventions, which goes some way towards his concern about trauma. But for today's purposes, I would be glad to explore this further. One of the limitations of the regulatory system is that a safety update is within our remit to impose, but to update by expanding an indication is not something the regulator is able to do, except through encouragement.
And in terms of where in the healthcare system responsibility might lie for trying to ensure that there is a greater use of tranexamic acid in place of transfusions where clinically appropriate. I understand the limitations of the MHRA's role as regulator. Whose role essentially would that be, do you think?
As I understand, Professor Roberts already has a grouping together with the Royal Colleges who will, if you like, help to set the standards, backed up, of course, by NICE guidance for how their members are expected to deliver care optimally. And I would see in this space the Royal College of Surgeons. I don't know if the Royal College of Obstetricians and Gynecologists is involved, but that sort of drive can be extremely helpful, as it was during COVID, working with the Royal College of Obstetricians and Gynecologists on uptake of the vaccine for pregnant women. So it's that kind of academic or learned society leadership.
And then a couple of more general questions, Dr. Raine. And these are the next two are questions that, for reasons which I hope will be apparent when I ask them, I've been asked to ask by core participants. Is it conceivable that a product, a medicine, could now be licensed for use if it was believed or known to transmit a serious infectious disease or virus?
It would be hard to imagine or justify a circumstance when a product would be licensed knowingly that would transmit or potentially transmit a virus, however innocuous a virus might seem, with the current scientific methods to eliminate or at least to reduce by vast levels a viral contaminant. We're talking here acid, solvent, heat, these terribly fine pores that a product can be subject to that would remove viral contamination. So in a nutshell, it would be very hard to imagine such circumstances. As I say, even if a viral contamination was considered to be of limited clinical significance, still, if the product were used in someone with a compromised immune system, that could prove a very serious consequence.
And then final question for now from me, Dr. Raine. You've worked in the field of pharmacovigilance medicines regulation for, I think, nearly 4 decades. What have been the main changes that you have seen over those decades?
The first, and I think most important, is the involvement of patients. And there is no better a representative of an experience than someone who has lived through it to say how that has affected their lives. We commissioned Professor Tony Avery from Nottingham to review our first 11,000 patient reports. And the findings fully demonstrated that patients will judge seriousness and causality, and in addition, the level of effect on their own lives in a way that helps understand risk. And I would say that in terms of the Cumberledge Review, the patients who have described the impact of those interventions have done far more than, if you like, academic or numerical or statistical analyses to convey what the safety system and how well it's functioned for them. I think in terms of the potential at the other extreme for the digital environment and data and analytics to really speed up the process so that we can get close to real time. We shouldn't need to wait to understand if a risk is real and if it's going to have an impact on the benefit-risk balance. So that really is an important step forward. And I think that the potential to link data sets, to use real-world evidence in addition to the kind of case reports that are so valuable as an early warning. It has been a discipline I've been privileged to work with and to see how much more and how much better we can do, but there's still more to do.
And has there been any discernible shift in the approach to risk that you've observed? Has there been, for example, a shift to a more precautionary basis?
That's a very real possibility for some things, but I think the more important shift is to understand better the risks that someone with a condition is prepared to accept. And there have been interesting studies in the field of multiple sclerosis, inflammatory bowel disease, where at different stages as a disease progresses, the acceptance of risk by the patient themselves can be quite markedly different from the health professionals' acceptance of that risk. So I think it's something that we need to get very much closer to and to align our own risk management requests to what kinds of risk management the user of the medicine, the patient, is willing to accept.
Thank you. So those are the questions I'm proposing to ask. If we could have a short break now, I don't anticipate needing more than 15 minutes.
Very well. Well, let's do that. The position is this: that those who are represented by legal representatives who are core participants have an entitlement to ask questions through counsel of you. Plainly, they need time to consider what questions they might ask, They have no doubt conveyed a number during the time that Council has been on her feet. But there may be more which arise out of the evidence you've just recently given or some earlier evidence, and Council must be given a chance to field those questions and put them to you. I can't tell you how long you'll be after we come back, but we'll take a break now until not before 4:45. I'm using that formulation, not before, because it could be later if there are a lot of questions which emerge, but you'll be told. But otherwise, 4:45.